our third and final grand rounds in the DEI series for this academic year. This is the 29th annual Gundry Lecture series, which was funded by the Gundry family in honor of Rachel K. Gundry. Dr. Gundry comes from a long lineage of psychiatrists, including her grandfather, father, and two uncles, all of whom were graduates of the University of Maryland Medical School. She herself was a very strong advocate for women in medicine and was the first woman to do an internship at the Baltimore City Hospital, now known as Johns Hopkins Bayview Hospital. So the Department of Psychiatry has dedicated this lectureship to mental health issues in the underserved communities in Baltimore, and has taken the opportunity to invite leading women in the field of psychiatry to discuss topics for us. And so with that, we welcome Dr. Hansen, and I will turn it over to Dr. Gordon, who will give us the introduction of Dr. Hansen.
Thank you so much for that. I will say I'm really delighted to introduce Dr. Hansen. I've had a couple opportunities to introduce her over the years, but this is by far probably the most exciting for me. I met Dr. Hansen in 2012 when I was a SAMHSA fellow for the APA Psychiatric Association. And she was gracious enough to come to New Orleans when I was there and teach the whole department of how to develop a curriculum around cultural psychiatry. But a lot has changed since then, and she's done some more wonderful work. But before I go into more introductions, I would just like to say that I'm really honored to be a part of the Social Justice and Education Curriculum Committee with my co-chairs, Dr. Hackman and Rachel Funk. This year, we engaged with our DEI Grand Round efforts, and this is the last one. I hope you guys had a wonderful time. Please give us feedback on how we did. It is our goal to interface with all faculty, didactic instructors, and work with them to embed diversity, equity, and inclusion and social justice in our work, and also create a repository of that information so you guys can have those educational opportunities. This is recorded, so please go back and look at it as you can. I also can't say anything without appreciating Dr. Forrester, who's our Chief of Diversity. This is the first time we've had a Chief of Diversity for the Department of Psychiatry. So thank you, Dr. Forrester, and also Dr. Jill Reichbeiser, who's not here today, but wanted to be here and also has championed DEI for the department. So without further delay, I introduce Helena Hansen. So Dr. Helena Hansen is an MD, PhD, psychiatrist and anthropologist. It was the first time I met two people who had two functions before. Is a professor of psychiatry and co-chair for research theme in translational social science and health equity, as well as an associate director of the Center for Social Medicine at UCLA, David Geffen School of Medicine. Helena Hansen earned her MD and PhD in cultural anthropology as part of Yale University's NIH-funded medical sciences training program. She is a professor and chair of research. I said that already. And she also did her fieldwork in graduate school in Cuba, Havana, around AIDS policy, and in Puerto Rico on faith healing and evangelical Christian addiction ministries founded and run by self-identified ex-addicts. Her work has been published in both clinical and social science journals, ranging from the Journal of American Medical Association and New England Journal of Medicine to Social Science and Medicine, and also medical anthropology. After graduate school, she completed a clinical residency in psychiatry at NYU Medical Center and Bellevue Hospital. During that time, she undertook an ethnographic study of the introductions of new addiction pharmaceuticals. That's amazing. In addition to that, she examined the social and political implications of clinicians' efforts to establish addiction as a biomedical rather than moral social condition, as well as the ways that neurochemical treatments may be reinscribing hierarchies of ethnicity and race. She completed a feature-length visual documentary based on this work, Managing the Fix, which I've seen and you guys should watch it too, Addicted to Christ, Remaking Men in Puerto Rico Pentecostal Drug Ministries, was published by the UCS Press in 2018, one of her works. She's also leading a national movement for training clinical practitioners to address social determinants of mental health. This university is engaging in developing curriculum for that. She led an effort with Jonathan Metzel who's also a psychiatrist and sociologist, around structural competency, which is a book. She also published a book around structural competency that you guys can probably have read on medical education and mental health. And all of these things are just a wonderful capture of who she is as a person. But more than anything, she's a humble clinician. She's a humble person who's going to delight us today with a lot of information. Look forward to your talk. And also we'll have a little conversation after this talk that many of you guys have put time in your schedule to participate in. Thank you, Dr. Hansen. We appreciate you coming today.
Well, thank you so much for that incredibly detailed and generous introduction. I've been so fortunate to have collaborated with Dr. Gordon on many projects over the years, and she never fails to amaze. I also want to thank, in addition to Dr. Gordon, Dr. Annika Forrester, Dr. Ann Hackman, Dr. Rachel Fink, and many others who made this possible today. As I pull up my slides, I also want to acknowledge that I'm speaking to you from California, which is quite heavily hit by the overdose crisis at the moment. But actually, Maryland has long been the epicenter and the bellwether for what's to come when it comes to the overdose crisis. And I just want to acknowledge how hard you all are working in Maryland to stem the crisis and to address its impacts. So it's actually quite auspicious that I would be speaking to you in Maryland. And I also want to say that I've been studying the intersection of race and addiction medicine for 2 decades now. And I started at a time when the media was publishing stories about the surprise of white, suburban, and rural opioid addiction. My study then quickly turned to how the opioid crisis came to be seen as a white crisis. Since that time, unfortunately, my disclosure, since that time, the plot has only thickened. And so overdose deaths in the US increased 40% since the onset of COVID. I mean, that's jaw-dropping considering how high our overdose rate was to begin with, the highest rate in the world, really. It's been marked, this increase in opioid overdose deaths since the onset of COVID has been marked by the fact that for the first time since the 1990s, the overdose death rate among Black Americans has exceeded the overdose rate among white Americans. So, and also Native Americans, the overdose death rate, that's what this graph illustrates. It was, and based on an analysis done by a grad student that I work with here at UCLA, who broke this news about the shift in the racial profile of the overdose crisis. So the plot is thickening when it comes to the overdose crisis. And it's now, we can say, definitely an issue of racial justice. But of course, what has made the overdose crisis of the past 20 years, or at least the discourse around it, different in many people's minds is the way the white identity of the sufferers has been highlighted in media and public policy. So it's a complicated story when it comes to race and the opioid crisis. I also want to put out a question for you to ponder during the talk that we can come back to at the end, because I'm aware that this lecture series is part of a series on women's mental health. And so it turns out that the overdose crisis is quite gendered. And that, for example, by the early 2000s marked the first time in a century that women were initiating heroin use at the same rate as men, and then exceeded the rate of male initiation of heroin use. So I want you to ponder that. How could that be? So if I don't get to it in the discussion, please remind me, because that is a very interesting question to untangle, to disentangle. So I'm going to approach race and health today from an angle that's unusual in medicine. I'm going to look at the mechanisms of whiteness in healthcare, and in particular in the field of addiction medicine that I've been tracking for the past couple of decades. I'm going to share a study of the hidden but active maintenance of white exclusivity in medicine as the cause of what we often call, quote unquote, health disparities among, quote unquote, underserved minorities. Groups that are typically described in a passive manner as lacking access to care. So I'm going to argue today that this is not actually a passive process. Whiteness is central to our environment in the US of profit motives, commodification, and the use of racial hierarchies to segment and open markets in healthcare and biotech. And it involves the mutual racialization of drugs and people. Drugs can be seen as white, as in targeted to white Americans, and they can pharmaceutically enhance the whiteness of people whose privilege is in question because of stigmatizing diagnoses like addiction. So I first encountered office-based medication for opioid dependence in the late 1990s. I was a medical student working with an attending on the wards on the early clinical trials of buprenorphine, which would later be manufactured with naloxone under the commercial name Suboxone. And my attendings at the time were excited about buprenorphine. They said it was about to, quote unquote, change the culture of medicine by defining addiction as a chronic disease, treatable alongside diabetes, hypertension, and asthma in the same clinics and in the same way with long-term pharmaceutical maintenance. So this caught my ear as an MD PhD student in anthropology. I asked, what could it mean to change the culture of medicine? And what would drive this change? So as it turns out, my attendings were right. In the course of my career, I've witnessed a profound shift in the way that clinicians and physicians frame addiction. So my field of addiction treatment swang from essentially a drug-free philosophy in the early 1990s to opioid maintenance, office-based opioid maintenance as first line of treatment by the 2000s. And as I completed an addiction fellowship and took a position in a psychiatry and anthropology department, I also documented stark differences between buprenorphine patients and methadone patients by race and class. So let me just show you a couple of images. So what began as a study of the culture of medicine became a study of how the opioid crisis came to be seen as white, ironically at the same time that racially targeted drug war policies led to mass incarceration of Black and Latinx Americans, giving the US the highest incarceration rate in the world. So while narcotics have long been criminalized through association with marginal racial groups, such as Chinese opium dens, cocaine-crazed Negroes in the American South, and Mexican marijuana madness. So by the way, this is 1914 New York Times. Very interesting how deep in history these racial associations go. And this is 1934, just before the Marijuana Tax Act was passed. We don't often look, though, at how symbolic association with white middle-class markets has legitimated widespread prescription of narcotics, including in post-World War II America, where epidemic overdose from barbiturates and benzodiazepines later haunted middle-class white America. We rarely ask how a drug can assume whiteness within a pharmaceutical logic based on race. And yet this process of pharmaceutical whiteness is at the core of the widely asked question, why, as of 2015, the life expectancy of white Americans suddenly was falling when the life expectancy of almost every other racial group was rising? And how did overdose become their primary immediate cause of excess death? So I want to go beyond the received wisdom that unemployed whites in the post-industrial Rust Belt turned to opioids for solace. So that might be true, but it begs the question of why opioids, why white Americans, and why in that moment? So I'm going to argue that the generation of opioids of the early 2000s were designed to have white racial identities, and that in our stratified healthcare and justice systems, the social technologies shaping opioid consumption reinforce racial inequalities while at the same time harming white Americans. And key to this story is an unrecognized form of ethnic marketing that, because it targets white Americans, works by not marking itself as racial. The story is invisible by design. And it was only through years of observation and interviews with key actors that I've been able to unravel the threads. So I've observed drug policy and addiction science meetings and clinical interactions over a 6-year period, interviewed over 200 addiction scientists, treatment advocates, pharma executives, policymakers, administrators, prescribers, and patients. And I'm going to start with this slide, which illustrates It's the first nationally representative study of buprenorphine, now commercially marketed as Suboxone, largely in combination with naloxone. And you can see this was from 2005, a paper in 2005. You can see that in the early years of treatment, it had a very specific race and class demographic. So it turns out that by 2019, this is another nationally representative study in 2019, almost 15 years later, published almost 15 years later, showing that that pattern persists. So even by the time of this study, white Americans with an opioid use disorder diagnosis were 3 to 4 times as likely as a Black American with opioid use disorder diagnosis to be offered buprenorphine treatment. And then payment method is revealing. The most common payment form is out of pocket for a very expensive medication that costs hundreds of dollars per month to maintain. Next common form of payment, private insurance, and much further down the list, public insurance. So that gives you a sense of who is getting this treatment, essentially. But what we don't know from graphs like these is by what process did buprenorphine and also methadone gain their racial identities? So for this, we have to go back in time. So let's go back to 1965. Race riots have burned through Harlem, Philadelphia, and Watts, Los Angeles. And the unemployment rate is twice that for Black Americans as white Americans in these center cities. Organized crime gains control of Asian heroin imports and recruits a sales force from Black and Latinx inner cities. Meanwhile, Rockefeller University-based metabolic researcher Vincent Dole and colleagues who think of heroin addiction as opiate receptor deficiency, analogous to insulin deficiency and diabetes. They published findings from their first clinical trial of methadone maintenance. And the study subjects are African-American heroin injecting men from Harlem. Its outcomes of decreased criminal activity and increased employment at 6 months while on methadone maintenance brings it national attention. And by 1970, news of methadone as a pharmacological answer to what is seen as an urban heroin crisis reaches President Nixon, who appoints pioneering methadone psychiatrist Jerome Jaffe as the nation's first drug czar. So Nixon targets inner city Black and Latinx people, as well as returning Vietnam veterans with methadone, which was his first weapon in the war on drugs. And to prevent diversion and street sale of methadone, the DEA regulates methadone clinics, requiring daily observed dosing and regular urine testing. Due to community resistance to the methadone clinics opening up locally, clinics are located in marginalized neighborhoods in the city, remote from other clinical services. So we're going to fast forward to October 8th, 2002, a new kind of opioid problem has developed following Purdue Pharmaceuticals' aggressive marketing of OxyContin as a quote unquote minimally addictive pain reliever. And most of the newly dependent people are white, many of them middle to upper income. The FDA has just approved the synthetic opiate buprenorphine, commercially packaged with naloxone and Suboxone, for maintenance treatment of opiate dependence in buprenorphine certified doctors' offices. Pharmacologically similar to methadone in that it blocks the opiate receptors in the brains of addicted patients, buprenorphine can be prescribed monthly for use at home, while methadone is still restricted to DEA-regulated clinics with directly observed dosing. So office-based buprenorphine represents a reversal of national policy. It's the first time in 80 years since the 1918 Harrison Act that private doctors are permitted to use opioids to treat opioid dependence. And to accomplish this, the manufacturers of buprenorphine and the architects of buprenorphine policy had to distinguish buprenorphine symbolically and spatially from methadone. So buprenorphine, pharmacologically in the same drug class as methadone, had to be whitened. So this is Mike in an internet ad for Suboxone. He's seated in his Ohio diner flanked by American flags and talking of returning to coaching his son's baseball team and singing in his church choir after buprenorphine rescued him from a prescription opioid habit following a back injury. So I let you ponder for a moment the race and the class imagery of this scene. But I want to argue that the ad was just the tip of the iceberg, that the whiteness of buprenorphine treatment was actively achieved by specific social technologies. And I'm going to give you an analysis from of the contemporary white opioid crisis in terms of what I call technologies of whiteness. And that is, those are social technologies of neuroscientific metaphors, policy, and industry strategies that maintain racial boundaries around biomedical uses of opioids. And the scheme is informed by whiteness studies, which it's a body of scholarship that proposes that one, whiteness is a category of exclusion and therefore requires cultural and political maintenance of its boundaries. So our cultural practices in the US are that not anyone can just declare that they're a white person. It's a socially maintained identity, meaning other people participate in that systematically in defining a person's racial identity. Second, white race is generally unmarked in America. It's the assumed norm. It's rarely explicitly mentioned and named, either in public policies or in the media. And the coverage of the whiteness, the images and discourse of whiteness in presidential politics, as well as of overdose deaths over the past 6 years, has been the exception that proved the rule. So, for example, I've discovered that white race is often signaled, and many scholars have documented this too. White race is often signaled with terms that code for whiteness without explicitly naming it. So, for example, in my media policy analysis of opioid coverage, coverage of the quote unquote new face of addiction, meaning white people who are involved in prescription opioid or heroin use, is the race of the people in those stories is signaled using code words such as suburban. While the race of Black or Latinx people with substance use disorder in media reports is mentioned explicitly, most often in relation to drug-related crime. Then third, whiteness is defined by its other. So white on one hand and Black or non-white on the other hand are interdependent. They define each other. And punitive American drug policy has long had a mutually defining twin of legal narcotics and over-the-counter heroin, actually a century ago, for middle-class Victorian housewives. Then moving to post-World War II barbiturates, stimulant diet pills, and Valium, otherwise known as suburban mother's little helper for white Americans, currently back to prescription opioid pain relievers. And then fourth, white privilege has its costs. So not only do white consumers in America pay inflated prices for prescription opioids, they pay with their lives in the form of overdose by lethal substances to which they have quote unquote privileged access. So the four technologies of whiteness that I'll outline include addiction neuroscience, new biotechnologies, regulatory structures, and marketing. And I'll start with the least visible of these technologies of whiteness, which is addiction neuroscience. So let's place buprenorphine development on the backdrop of President Bush, the first decade of the brain. This was the 1990s. It was an era in which NIDA, National Institute on Drug Abuse, was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project. And in the process, NIDA renamed addiction a chronic relapsing brain disease. So this was supported by leading NIDA-funded researchers who co-authored this widely cited article published in JAMA at the end of the decade of the brain. And in it, they argue that narcotics dependence is comparable to diabetes, hypertension, and asthma in terms of its heritability, treatment adherence, and relapse rates. And as such, it should be treated as a chronic medical disease. The scientists involved in this movement had a social justice intent. They wanted to destigmatize addiction by demonstrating that it's a legitimate biological condition and not a problem of morality or choice. What they didn't anticipate was that the scientific universalism underlying addiction neuroscience, because it implied a standard white male subject, would help to open white markets to new opioids, and that the unequal ways that biotechnologies are disseminated would enhance the social stratification of addiction treatment. So for example, brain images like this, by taking out the subject and his or her trappings of gender, race, and class, taking literally the organ, the offending organ, the brain, out of the body altogether. So you don't know, where did this brain come from? What neighborhood? What was the race, class, gender, et cetera, of the person? It's a brain. This conveys an unmarked universality of addiction physiology. And neuroscientists further reduced causation of addiction to molecular action at neuroreceptors, the ultimate disembodiment of addiction. So the apparent universality of this molecular model implied an assumed white norm. It took a problem long associated with Black and brown crime and gave it a new implicit association with white people. And in the process, however, it excluded social conditions. The scientists involved wanted to counteract a drug war mentality by erasing the social context of drug use. Yet they paradoxically set the stage for renewed racial stratification of opioids. So the next technology of whiteness, if you will, is new biotechnologies. And it turns out that the neuroscientists I just mentioned unwittingly aided corporate strategists that capitalized on this erasure of the social. Building on the neuroscientists' ideology of technological solutions to addiction, in '96, Purdue Pharma got FDA approval for OxyContin and was able to market it as quote unquote minimally addictive, suitable for chronic management of moderate pain. And this was based on its patented sustained release capsule technology, which in theory lowered the reward for users by preventing an initial rush to the brain. The manufacturer influenced the National Joint Commission on Hospital Accreditation to call for pain to be aggressively monitored and treated as quote unquote fifth vital sign, along with high blood pressure, respiratory rate, pulse. And drug reps advised new opioid prescribers to direct OxyContin to quote unquote trustworthy patients as an additional safeguard. And in a national clinical workforce that's been shown to suspect non-white patients of drug abuse, this implied white patients. Of course, what the model of addiction-proof biotechnology left out of this was the social inventiveness of drug use. OxyContin users interested in a rush quickly learned to crush and snort or inject the contents of each capsule. And after steep increases in opioid overdose, public pressure mounted for intervention. As of August of 2010, this is 2010, just as the original patent on OxyContin ran out, Purdue Pharma introduced its new tamper-resistant time-release formulation, embedding oxycodone into polymers that convert tablets into gummies should users attempt to crush and dissolve to inject them. By keeping prices high and representing OxyContin as technologically sealed off from misuse, the manufacturer strove to keep OxyContin symbolically a step ahead of urban, non-white street markets. Another biotechnology developed specifically in response to the white suburban and rural prescription opioid epidemic was buprenorphine itself, combined with opioid antagonist naloxone, branded Suboxone. Reckitt Benckiser Pharma promoted this combination as a smart drug. Although buprenorphine is an abusable opioid, the naloxone with which buprenorphine was combined caused withdrawal symptoms if injected, but not if dissolved under the tongue as prescribed, since naloxone could not be absorbed sublingually. And buprenorphine also posed a lower risk of overdose deaths than other opioids. So by the 1990s, NIDA subsidized Suboxone's manufacture with $23 million to test it for use in addiction treatment and sharply distinguished it from methadone, lobbying Congress and the DEA to lower the abuse potential rating of Suboxone from narcotic Schedule 2, which is where OxyContin and methadone fall, to narcotic Schedule 3, along with codeine cough syrup. And this is what made it possible to prescribe Suboxone in private doctors' offices. The manufacturer also lobbied Congress to get Suboxone included under an orphan drug clause designed to promote pharmaceutical development for unprofitable diseases in low-income countries like malaria drugs. Suboxone's designation as an orphan drug got it a patent extension through 2009 on a drug initially developed in the late 1960s. In a race and class stratified healthcare system like we have here in the US, where access to general doctors is often limited to those who can pay, patented expensive technologies for private office delivery in themselves encode white race and middle class. The third technology of whiteness is regulation. So although by 2004, prescription opioids overtook heroin as the primary opiate of abuse in the US, the arrest rate for their illegal possession was 1/4 that, the arrest rate for heroin, and arrest for illegal sale of prescription opioids was less than 1/5 that of the arrest rate for selling heroin. Not coincidentally, the quote unquote non-medical use of pain relievers was twice as high among white Americans as Black Americans at that time, while rates of heroin use among Black, Latinx, and white Americans were almost identical. Since suburban and rural white opioid users were not politically popular targets for drug law enforcement, the DEA and other regulators focused their surveillance and enforcement on prescription opioid prescribers and pharmacists instead. And one sign of this was the spread of prescription drug monitoring programs, now enacted in all states, half of which mandate prescriber participation with threats of loss of license if a prescriber does not look up a patient in a database to see if they've been prescribed narcotics elsewhere before prescribing a narcotic. So returning to buprenorphine, otherwise known as Suboxone, the Drug Addiction Treatment Act of 2000, dated 2000, passed by Congress, enabled any certified physician to prescribe Suboxone in the privacy of their own office. And in congressional debates leading to passage of Data 2000, there was a clear emphasis on a quote unquote new kind of user, one that is young, suburban, and quote unquote not hardcore. So these are code words for white Americans. Recorded testimony from federal officials stressed that buprenorphine was uniquely appropriate for a new kind of opioid user as opposed to methadone, quote, which tends to be concentrated in urban areas and is a poor fit for the suburban spread of narcotic addiction, end of quote. Then Health and Human Services Director Donna Shalala was one of many officials who noted that buprenorphine as an alternative to methadone would serve a quote, new kind of addict, including citizens who would not normally be associated with the term addiction, end of quote. With this racially coded language in which suburban and new kind of addict referred to middle-class white Americans, Data 2000 passed Congress and reversed 80 years of federal prohibition of private physician opioid maintenance for opioid dependence. So Data 2000 kept the restrictive and highly regulated methadone system intact and did nothing to alter drug laws that mandated inner city heroin users to prison, but it did create a new treatment track for those with the resources to take advantage of it. To give additional assurance to the DEA that buprenorphine wouldn't spill over into illicit markets, buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, developed an 8-hour certification course. I bet many of you on this call have been through this course that was required for doctors to prescribe buprenorphine. It was the first and only prescription drug in the US to come with such a requirement. In my interviews with public sector doctors, I've learned that the certification requirement is a major barrier to making buprenorphine available to low-income people because public clinics don't provide time or incentives to pursue certification, while prescribers in the private sector can charge fees of up to $1,000 for an initial induction visit for buprenorphine prescription. The shortage of public sector prescribers, along with the cost of buprenorphine itself, have long kept buprenorphine in the private sector. And I just want to flag that actually Baltimore is an exception to this rule because those of you working in Baltimore will know that actually local universities, including Maryland and Johns Hopkins, ran early clinical trials of buprenorphine. And they engaged local practitioners with it. So there's a lot more access in Baltimore for publicly insured people than in other parts of the country. So in a sense, you serve as a model for the rest of the country. The fourth, technology, whiteness, media, and marketing. So OxyContin's legendary commercial success hinged on its designation as a quote unquote minimally addictive opioid analgesic. And when OxyContin was under review at the FDA, Purdue estimated the addictive potential of OxyContin to be 1% based on testing among terminally ill cancer patients for a 3-month period. So in '96, FDA accepted this claim and enabled Purdue Pharma to open an opioid market and other manufacturers of similar opioids to open a market that had previously been restricted to those with severe acute pain like post-surgical or cancer pain. They were able to open a new market, a much larger market of patients with moderate chronic pain, such as lower back pain, that were being seen by primary care doctors. They hired almost 700 drug reps and canvassed a call list of 100,000 physicians in the first few years alone. And Purdue targeted general doctors in white suburban and rural areas that served patients that the public and the DEA did not think of as at high risk for opiate addiction and diversion. Purdue's strategy paid off. It led to a 10-fold increase in prescription opioids nationally, with the disproportionate uptake of OxyContin by prescribers in white suburban and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. So in a newspaper content analysis that I completed, I found that in contrast to articles about the criminality of Black and Latinx drug users, suburbanites addicted to OxyContin were portrayed sympathetically in the media as victims of overprescription or as people struggling with physical or existential pain. Ironically, Purdue's technological response to the first wave of white prescription opioid overdose deaths, their tamper-resistant formulations of oxycodone, combined with new prescription drug monitoring programs, led many of these opioid users to look for heroin when pills became hard to get. And one consequence of this was a whitening of the media coverage of heroin users who'd long been portrayed as Black or brown. So this is a suburban school teacher in upstate New York. And this is a college athlete in Arizona, two of myriad images at the time. The targeted intervention for these new heroin users, buprenorphine, otherwise known as Suboxone, was marketed to middle-class insured patients over the internet. So manufacturer-sponsored web-based public service announcements featured white professionals and business owners on Suboxone maintenance. And you see some of that coding on this homepage for a website with ads for buprenorphine. This same website features a link to a Suboxone prescriber locator service that was created by the Federal Substance Abuse and Mental Health Services Administration, along with the manufacturer. So browsers can enter their zip code. You see in the lower left-hand corner, patients find a buprenorphine physician, you put in your zip code, you get a list of Suboxone certified Suboxone prescribers in your area, most of them in private practice. So these strategies created an exclusive but lucrative segment of the market for Suboxone, making it a blockbuster drug at over $1.5 billion a year in US sales by 2012. Second in that year only to OxyContin, which reported US sales of $3 billion in 2012. So in conclusion, the racial segmentation of drug markets into licit and illicit, white and Black, clinical and recreational, creates a moving target of time-bound patents on new technologies, targeting the white middle class. And this is an old cycle started by Bayer Pharmaceuticals' own heroin, marketed as a non-addictive alternative to morphine for white middle-class Victorian housewives in 1898. So I'll just let you ponder that. It was also marketed as a highly effective cough syrup for the children of these housewives. So what can we learn from this as clinicians, researchers, policymakers? I want to argue, number one, that magic bullets are a myth. As the failed promises of OxyContin's sustained release capsule and the inability of unilateral buprenorphine marketing to stem overdoses have shown, biotechnology alone cannot stop the harms of narcotics without systemic and social intervention. And to underscore this point, I'm going to turn to an international comparison that my colleagues who are buprenorphine advocates, buprenorphine expansion advocates in the US often turn to, and that is France. So in France, where buprenorphine was adopted for general physician treatment of opiate dependence in 1995, it was billed not as a stigma-reducing agent for a middle-class white market, but as a public health intervention to stem overdose and HIV among low-income, largely immigrant heroin injectors. So buprenorphine was widely adopted among primary care doctors in poor communities in a country, I want to underscore this, in a country with universal health care. So it's a country where there are very low barriers to getting care with a primary care doctor, unlike in our country. So you see from this graph, this is a very famous graph, that in the first 5 years of buprenorphine dissemination in France, the opioid overdose death rate dropped by 80%. And one thing that is left out of the story when we in the US only focus on this graph, we focus on the buprenorphine itself. And what we don't realize is in France, buprenorphine is offered along with methadone in community-based addiction centers that are quite comprehensive, that offer comprehensive healthcare, also comprehensive social services, including assistance with housing, employment, income, childcare. They also offer harm reduction services on site so that people, wherever they are in their spectrum of treatment recovery, can get syringes, clean syringes and equipment. They also have supervised injection facilities. So that's something that we don't have in this country, that kind of approach. And this should make us skeptical about the power of the market to protect the public and rectify inequalities in health. So in our for-profit healthcare system, so we don't have universal healthcare here, and we don't have the same system that France had too. In France, they never had the opioid crisis, the overdose crisis that we have. So you'll see in the upper left-hand corner at the peak of the French overdose crisis, they had 565 deaths in a country of 60 million people. So that's 2 orders of magnitude lower than the death rate in our country. Why? OxyContin was never approved for the uses that it was approved here. In France, they have a national review body that has strict prohibitions on any ties to pharmaceutical industry of its members. And that body did not accept the clinical advantages and safety of OxyContin. Okay, so in our country, however, with its for-profit healthcare system and very sharp social inequalities, buprenorphine treatment has followed the pattern predicted by theorists of fundamental causes. Let me go ahead to this article. So Bruce Link and Joe Phelan, theorists of fundamental causes, they predict that new biotechnologies in a system of sharp social inequalities like we have, unless those social inequalities are addressed, will widen rather than narrow health inequalities, as long as the social inequalities, the social drivers of health are not addressed. And that's exactly what's happened with buprenorphine. I remind you of this graph that I showed in the beginning of my talk. Okay, then second, problem drug use is biosocial. And what do I mean by that? So first of all, our life science colleagues are increasingly showing that the brain is a plastic organ that has evolved in response to social environment. And so the interface of social environment and biological systems is a very dynamic one. And so neuroplasticity, epigenetics, and the microbiome, those are emerging paradigms in life sciences that demonstrate that kind of dynamism. If we are to take seriously the comparison of addiction as a quote unquote chronic brain disease with asthma, diabetes, and hypertension, we'd recognize that each of those conditions, asthma, diabetes, and hypertension, has strong social determinants as well. So even if we accept that addiction is a brain disease, we have to look to other chronic diseases and show that success in their treatment and prevention requires social support, access to fresh food, safe, unpolluted, walkable neighborhoods. So the biological elements of something like addiction still point us towards intervention at those levels. And then lastly, deaths of despair call for racial and economic justice. The 2015 report on US white life expectancy that I started off with, one thing that is incomplete in this report, it's a very interesting report written by economists that highlight the economic decline of the centers, the rural and small town Rust Belt centers where opioid overdose was initially concentrated. And so they highlight the impact of deindustrialization. Oops, can you hear me? Okay, I want to make sure that you can hear me.
Yes, we can hear you.
Oh, good. Okay. They highlight the impact of deindustrialization and unemployment in manufacturing and mining industries where employers have left for cheaper labor pools. and the fact that social ties, this is a famous sociological study showing social ties are thin in these areas as a result and linked to opioid dependence, opioid overdose. The argument is persuasive, and it calls for social and economic revitalization through policies that promote social integration, stable employment, and livable wages and benefits. So not just public-private partnerships to develop, approve, and disseminate new medications for addiction. I'm sorry for the background noise. As are currently prioritized in our national opioid policies. But their focus on white Americans makes the analysis incomplete and makes Black and Latinx overdose deaths invisible. Case and Deaton, the authors of the article, didn't have a clear explanation of why Black and Latinx life expectancy did not decline in the time period of the study. But I want to posit that Black and Latinx Americans saw an overdose crisis 30 to 40 years earlier, with influx of heroin to inner city neighborhoods between the 1960s and the 1980s. So blue collar workers in Black and Latinx neighborhoods were often barred from unions. And they were the last hired, first fired. And they saw massive unemployment much earlier than white workers who were initially protected by industrial discrimination. So this earlier Black and Latinx opioid crisis was not seen as a health crisis. It was reported in the popular press as an epidemic of crime, and it led to white flight from cities that further disinvested Black and Latinx city neighborhoods. And we're left from the survivors of that earlier crisis. So let me just go ahead to, these are general recommendations moving forward. We really need to focus on universal comprehensive healthcare. We need to focus on nationally decriminalizing opioid use and substance use dependence, promoting harm reduction and treatment. And we also need to focus on that biosocial interface that I was describing. So understanding how our interventions at the level of community living conditions and employment and housing, all of those can help to prevent overdose crisis, to mitigate the overdose crisis. And then I'll just spend the last few minutes or 2 minutes or so on an approach that Dr. Gordon asked me to highlight that I've been working on with colleagues to address what we call structural drivers of social determinants of health. That is structural competency. I distinguish structural drivers from social determinants in that in our clinical work, we're getting more and more accustomed to screening for social needs in our care. And so we might ask patients if they have stable housing. But what we don't often do is step back to ask, why is it that certain populations, I'm going to plug in my computer, why is it that certain populations have higher rates of unstable housing than others? So for that, we have to look to city and state zoning laws, development plans, predatory lending schemes that explain that those population level, those neighborhood level inequalities. And the same holds for legal involvement. So we've had a year and a half of talking about why it is that law enforcement is so much more intense and sentencing so much more intense in certain neighborhoods than others. So structural competency. Okay. So structural competency is a term that I and Jonathan Metzel and a growing network of colleagues have introduced to highlight the need to shift our focus above the level of the individual patient and to institutional. By that, I mean, for example, law enforcement, schools, and housing agencies. So institutional level drivers of health outcomes, community conditions, and public policies that determine health. And then competency is a term that we use to indicate that we as clinical practitioners need skills and need to take responsibility for intervention at those levels. So we have symbolic, social, and cultural capital to bear in intervening on institutional structural drivers of health. And the competencies, in short, include recognizing and articulating the structural, the institutional level drivers of our patients' health outcomes, and then observing and practicing structural intervention. That's the hard part. I'm going to give you just a few brief examples in closing of that, how we can provide more opportunities for our trainees to see one, do one, teach one. And then we also need to develop structural humility through collaboration with partners who have expertise that we don't have, such as policy advocates, community organizers. So just very quickly, I'll walk you through levels of structure that we can intervene on. The lowest hanging fruit is right in the clinic where we already practice. Many of us are now embedding questions about social needs, such as stable housing, into our electronic medical record-based assessment tools. And just doing that greatly increases the rate of referrals for social services. Many of us are now engaged with medical legal partnerships in the clinic, where we're working with pro bono lawyers or law students to address problems that lend themselves to legal interventions, such as eviction of our psychiatric patients when they become symptomatic by landlords that are violating the Americans with Disabilities Act. Also, social prescribing, meaning that there are many ways that practitioners, physicians can write prescriptions for a patient to get help with a social problem, such as help with applying for Social Security disability benefits, and then hand that prescription to an agency or peer navigator that will help to walk the patient through that, leaving me with peer navigators as parts and community health workers as members of our clinical teams. That in itself is a structural shift in our clinical provision. Next layer, the next level of structure we can work on is non-health, collaboration with non-health agencies. So I mentioned housing agencies, I mentioned law enforcement, I mentioned schools. Another is urban planning, given that in the US, racial segregation is such a strong driver of health outcomes. My mentor and colleague, Mindy Fullylove, has done a lot of work in working with urban planners and architects to integrate US cities as a health intervention. So she's come a long way in cities like Pittsburgh, Pennsylvania, and Orange, New Jersey, and taking down things like highway overpasses that segregate cities by race and class, and creating common green spaces and integrating neighborhoods on many other levels. Another level of structure is partnering with community organizations. And here I'll just briefly say on the right is my colleague Ayana Jordan, who you may actually have heard from, if I recall. So she has been partnering with Black and Latinx churches to provide addiction treatment and recovery support in churches, trusted, safe spaces, places that populations that are often very marginalized and stigmatized within traditional biomedical clinics feel that they can go, and had a lot of success with that. And then lastly, I'll leave you with public policy. We do have a role to play as physicians, as practitioners. And on the lower right-hand corner, from punishment to public health, that's a New York-based collaboration between practitioners, formerly incarcerated people, and disenchanted law enforcement officials, criminal legal system officials. They're working to redirect people away from incarceration towards treatment. One way they do that is that they train clinical practitioners, clinical practitioners to give testimony to policymakers and to write op-eds, so to weigh in on the health effects of public policies. And I'll leave you with this image, which is really an invitation to join our national network. And we're busy uploading training materials and other materials, curricular materials, to share across campuses. So with that, I know I haven't left much time for discussion, but thank you very much.
Thank you, Dr. Hanson. I think you left a lot of time for discussion, which is nice. We have until 1:30. People start trickling out probably like around 1:20, but thank you for giving us the time. I had a question in the chat box, and I think you may have answered it, but I'll go back to it. And what was the question? Like, I was wondering if you could discuss more, like this codification is the term that I'm becoming more accustomed to when I read journals or articles or think about medicine and how we describe patients and our interactions with them. But can you discuss more the codification of whiteness and also the codification of people of color in the medical literature, and how we can, advance some of our work and our understanding about how we communicate with each other that signals the treatment outcomes from a structural lens, and what we can do to practice better when we see those things happen?
That's such a fantastic question. And I I don't know if there's a really simple answer, but I think that over the past 2 years, I see in the chat someone has noticed that my dog has been barking. I apologize for that. So I hope that that dies down in a moment. But over the past, I'd say, year and a half, we've had much more of a national conversation in academic medical centers about the use of race in medicine. And it turns out, yes, language is powerful. Language can be used to highlight things. Language can be used to signal relationships. I spent some time in the talk showing where some of our racial imagery of who uses drugs comes from. And the very omission of direct race references to race when it comes to white Americans, I've argued has had an impact. It's had an impact in biomedical research because we have been carrying a lot of assumptions about the race of the research subject and the race of the people represented in our studies. With the coded language, the kind of euphemisms around whiteness that we use. We've also taken out of view race and other markers of identity by not naming them explicitly. So I think the move forward over the past couple of years in reaction to very obvious inequalities in COVID outcomes, treatment and outcomes, and also in reaction to the Black Lives Matter movement and related movements, is that we are speaking openly and consciously about how we're using racial language and designations and markers in biomedical research and also in clinical treatment. There is not an easy answer. That would be, we would be asked to disentangle centuries of implicit and explicit racialization of bodies in healthcare and in biomedical research within a 2-year period. Basically we're faced with a tangled mess. And the first step is to be much more aware and much more sophisticated in our understanding. I think there's more explicit acknowledgement in this moment in academic medicine that we cannot, for example, assume that racial inequalities in health outcomes are due to some unidentified gene. When I was a medical student, we were taught that Black Americans had a much higher rate of hypertension than white Americans. And we were not given a causal explanation. And we were left to, and sometimes, our lecturers, our professors would reference the possibility of an unidentified African gene. So in my field, my other field of cultural anthropology, there's been comparative international work showing that, for example, hypertension among Black people living in West Africa is not anywhere near as prevalent as hypertension among Black people living in the United States. And actually hypertension among white people living in West Africa is lower than among white people in the United States. So that begins, and that's true also of other countries that are comparators to the US, where certainly racism exists and has its impact, but it's not experienced on an everyday level in the same way as in the US. And so living in a country where Black people are in the majority is a different experience than living in the United States, where Black people are not only in the minority, but are experiencing multiple layers of structural racism in their interactions. And I've outlined in my talk how structural racism has worked with drug policy, and in particular opioid policy, and harmed white people, along with Black people and others. But I just want to use that as an example of the nuance of racial markers and what they actually mean. And one other study that I want to reference from my colleagues in cultural anthropology, going to Puerto Rico, which is a very racially mixed place with colorism, where colorism is kind of the prominent mode. And so in Puerto Rico, my anthropology colleagues have done studies where they have looked at hypertension in relation to self-rated skin tone and then objectively rated skin tone with a chronometer. And what they found is that self-rated skin tone is a really good predictor, skin color shade is a really good predictor of hypertension, whereas the objectively rated skin color is not. And so they've highlighted that it's actually self-perception of racial identity and skin tone in a society with a quite strict racial hierarchy that is relevant to hypertension. So these are just two examples of the level of nuance that we could use moving forward with the questioning of very, of a century of quite simplistic and often biologically determinist ideas about race, that it's somehow that race has a biological basis, probably a genetic basis, that the social categories that we operate with are rooted in genetic code, and that these explain health inequalities. So we're coming out of a century of that kind of thinking, often genetic determinist thinking. And we now have the opportunity to embrace the complexity here and to look even at racial predictors of health outcomes as biosocial.
Thank you for.
And I'm getting some sympathy from other people who have dogs who are passionate about Zoom calls.
I was thinking about what you said in terms of the racial stratification and codification, but then I also think that in medicine we do that as it relates to other demographics, particularly women versus men. And I just remember in medical school wondering, why do we keep saying women get more mood disorders? Like, that just annoys me. But I think the way we cluster, these symptomatologies and think about it, we never really talk about the social implications of why a woman would, for instance, have more depression in a society that has been oppressive in many ways. And so over generations, over centuries. So I just think that it's just an interesting way to read journals now to codify it before you even actually read it. Someone asked the question, can you make any recommendations for training to help improve medical note writing to decrease stigmatizing, racializing, prejudicial language, and instead use language that promote quality care and partnership?
That is a lovely question. So I wonder if I could do two things, because you brought up gender, and I had posed a challenge to this group around the gendered nature of the overdose crisis as well. So I wanted to come back to that point and acknowledge that what you're saying is true, that there are many parallels between race and health outcomes, the way that we simplistically have been talking about them in biomedicine for a while, and gender and health outcomes. Why is it that women are more likely to have certain kinds of outcomes than men? And of course, one of the things that we're leaving out of the picture is exposure to the gendered hierarchy of our society. What is the impact of that? So when it comes to the opioid crisis, it turns out that over a century ago, there was an overdose crisis from heroin and related opiate products that often were even sold over the counter. And that targeted housewives. So middle-class housewives who could afford private doctors, vast majority of them white women, would have morphine injections for menstrual cramps, And so, so the first opioid crisis, if you will, was highly gendered in that way. It was also gendered in that many of the early opioid addicted people over a century ago were Civil War veterans who were getting morphine for injuries, war-related injuries. But women were quite prominent over a century ago among users of that, at that point, legal opiates. And then as prohibition movements came around, one thing I didn't mention about those racialized images, you saw the Chinese opium den, cocaine crazed Negroes in the South. Those media stories came out at a moment in US history when prohibitionists were using those images to get prohibitionist policies passed. So they led, for example, to the illegalization of heroin and cocaine, which had actually been accepted as part of the pharmacopoeia at that time. So race and drugs have long been linked together when it comes to drug policy. Non-white images were used to pass prohibitionist drug policies over a century ago. And in that moment, the gender of heroin users flipped. So as these narcotics were illegalized, middle-class female users were less common. And they, in turn, went for other legal narcotics. So I showed the image of the white middle-class clientele that early barbiturate ads were targeted to, and benzodiazepine ads were targeted to. So women have long been, middle-class women have long been targeted for legal narcotic prescriptions and had been in the minority after illegalization. Prohibition was successful. Illegalization of narcotics that were associated with Black and brown people. With the women that had been using those drugs when they were legal went to the legal market. So what's happened in the past 20 years in our current overdose crisis is that women, so the OxyContin's manufacturers, Purdue Pharma and also Endo Pharma, and the whole laundry list of opioid manufacturers that participated in the gold mine of deregulated, quote unquote, minimally addictive opioid pain relievers of the late 90s to early 2000s. They saw that the major market was actually a female market for opioids, opioid pain relievers, legal opioid pain relievers in primary care settings. Because women disproportionately see primary care providers and disproportionately report pain as a major complaint. So what you'll see in those early ads is they're disproportionately showing women. Early ads for OxyContin, that was a targeted market. And then in turn, as those opioids were taken off market and more tightly regulated, you now had a whole cohort of women who were opioid dependent and who turned to heroin, and a culture of new heroin users that was much more female gendered. So I'm just telling this story as a way of showing how much more nuanced and interesting the story gets if you start to dig and you start to look at how gender and race are socially constructed, right? Because in our society, really, it's women who are culturally permitted to have pain complaints. It's women who are encouraged to see primary care doctors, and it's women that are disproportionately marketed to when new pain relievers are approved. So that's a very long-winded explanation, but I think you're absolutely right to highlight that there are parallels here, race and gender, and then of course, the intersection of race and gender, because what we find is, for example, Black women who use opiates or other substances on the illegal market are at extremely high risk of overdose. One of the factors that I didn't get to mention is fentanyl, but I'm sure you're quite aware of fentanyl and other high potency synthetic opioids in Baltimore, because they're quite common in Baltimore and causing a lot of opioid overdose deaths. Mm-hmm. One thing you'll find when you start to dig deeper about why it is that Black overdose deaths have accelerated so greatly is that fentanyl exposure is more common among Black people and among women. And if you dig deeper, you find that the lower you fall in the power structure, the more likely you are not to have control over where your supply of drugs comes from and to be exposed to fentanyl. Mm-hmm. So I'm just kind of painting a picture of what a much more multi-layered and rich picture you get if you start to dig into the social context and how race and gender actually play out on the ground. And so then back to that question, I think this somehow relates to the question about how can you improve medical note writing and decrease stigmatization, racialized prejudice language. So here, I think it's not just the language, it's language as reflected in clinical problem solving. So what I know you, Dr. Gordon, and many of our colleagues have been working at is to help improve the skill level and sophistication of our colleagues and our trainees in understanding how, for example, race and gender actually impact them. So this is something that's extremely clinically relevant. So not to stop at labeling somebody. Often what we do is we based on our visual impression of someone, we'll label someone Black or whatever other race. We do not engage them in a conversation about not only their identity, but what that means for them in their daily lives. So that is actually where we need to go. We need to understand not only that somebody perhaps self-identifies as a white person or as a Black person, as a woman, as a man, we need to know what that means for them and contextualize their clinical presentation based on where they're coming from and what their experiences are. We're not going to get very far unless we do that. And I think that the fact that we have a healthcare system that has structured out the opportunity for that, that's really limited patient contact time and really taken the priority off of our contacts, our interactions with patients and getting to know who they are, and put the priority on prescription of pharmaceuticals, because that's where the majority of our healthcare dollars are going, is devices, pharmaceuticals, procedures, as opposed to the social interaction between doctor and patient, practitioner and patient. That is a barrier to effectively addressing these problems. And of course, I wouldn't want to stop at the level of how do we interact with patients on a one-on-one level. I'd want us to take our understanding from our conversations with our patients to the community level. And as I was highlighting in that end piece on structural competency, get to know the community from which our patients come, interact with community organizations there, figure out how we can build partnerships, because what's really important for patients is what happens when they leave our clinic. They spend the majority of the time in their neighborhood, not in our clinic room. So anything we can do to improve the chances of their recovery outside of our clinic, that's a good investment of our time, and having partners that can do that, because we're not capable of doing that on our own, but in collaboration, we can create more recovery supportive, health promoting environments. And that's also true for, as I mentioned, non-health agencies like housing agencies, legal aid. That's also true for policy, that it's a good investment of our time to partner with people at those levels to improve the environment in which we're sending our patients. I hope that begins to answer a very complicated question.
There's two more questions, and I have like a short comment when I thought about a woman from a marginalized group. So I had a patient who has bipolar, and she was vicariously shot as she was walking to the store, like a gunshot wound, and was sent to a pain management clinic. And I coached her on how she should present herself, because she's oftentimes irritable and agitated. She went to the clinic, and of course she was irritable and agitated, and she was kicked out of the clinic, and they refused to give her pain management. As a result of that, I petitioned, I called the clinic. I said, hey, this is a patient who has a mental illness. She needs this pain medication, is really serious. Our doctor has already made the referral. Can we help? I can come to the clinic as a mobile treatment program. We can bring, So I did all the negotiation, and they agreed to see her. However, when she went in the room with the doctor was so agitated after the last meeting that she went in. She said, I don't think you're a good fit for this clinic, but I can refer you to another place. And guess what that other place turned out being? A marijuana clinic. So now she has a medical license for marijuana. I was like, how is it ethical that you can send her away from a pain management clinic for a medical condition that you clearly know she had? And the same token, you can refer her to another clinic that you work at to give her marijuana. And so I was very frustrated and demoralized, and also leaving the place that I was working. So I wasn't able to convince this patient that medical marijuana is not what she needed to resolve her pain issues and anxiety and bipolar and all of that. And so I do think that some of the policies that we have huge implications. And obviously this addiction crisis is not my subspecialty, but it impacts everything we do. And this is a woman who have kids. And so obviously it's gonna impact the next generation. But there's a lot of great questions here. I just wanted to share that with you because that's what I was thinking.
Well, it's such a great case. No, Dr. Gordon, that's an excellent case, because what it highlights is a tension that I carry around with myself. I'm a buprenorphine prescriber. I'm a methadone prescriber. At the same time, I don't think, I argued against magic bullets. I said, there's no one medication, no matter how great it is, that's going to solve all of our deeply embedded social inequalities, right? And in fact, if we don't address those social inequalities, we're going to widen the health inequalities as predicted by fundamental causes theory, right? So I carry that contradiction around with me. And so I think that there are multiple levels of intervention that we have to be acting on. There is a shorter term level of intervention where in some cases, medical maintenance of opioids, marijuana for pain, what have you, could be useful. And of course, we train for many years so that we can make complicated, nuanced judgments, right? There's no easy answer to this. There are some people that need maintenance in the short run or even over the long haul. because that does improve the quality of their lives under the circumstances that they live. You know, we deal with reality. We deal with people who may not be in a position where they can successfully get off of opioids, get off of marijuana. I'm a big believer in harm reduction. You know, we're often left with how can we reduce the harm from substance use and also reduce the harm of drug policy that is often the cause of the most harm. If somebody's getting arrested for marijuana, they now have a legal record, they don't have employment, they don't have access to subsidized housing, they're left with a whole host of other problems, right? Because of drug policy. So there's harm reduction. There's a role for harm reduction. There's a role, I believe, for medical maintenance, both with opioids and in some cases with marijuana. But there's also a big role for addressing root causes so that we have many more options than that, so that we can also help patients when the time is right, when the circumstances are right, we can support them in not needing medications. You know, that's also, I don't want to give up on that really big goal that we could be building towards social conditions and a society where they can be in recovery successfully without substances also. So we need the whole range. You know, I guess that's what I argue. But there are nuances. So the way you tell the story tell me that there's something not quite right in this sequence when it comes to this patient. And that's why we need nuanced clinical judgment about this. And we need to be skillful both with harm reduction and with recovery support and with structural intervention. And you're right, there are some really great questions here. Should I just take them one by one?
I'm going to try to combine them together, Helen, and help you. And we have about maybe 10 minutes. So the question on, this is a great question about how we can make medicine apolitical. There's so much independence of technology, of whiteness, and it's closely relied to political agendas and policies and social propaganda agendas in a sense. And then the other question that came up was whether there should be extra training required for prescription buprenorphine as opposed to other scheduled medications aside. And could that buprenorphine training be an opportunity to address the racialization of the issue? I think those two questions kind of fit together, because oftentimes these policies, these practices that we do is based on some type of an agenda. And some of us may be aware of what the agenda is and others may not. So I don't know. That's how I think about it, but I wanted to see your response.
These are fantastic questions. And as you can imagine, I often get, when I'm talking about structural competency, I often get this question about, well, shouldn't we be apolitical as practitioners? Because that's kind of the dogma that we're given, that medicine requires us not to engage in politics. It's kind of the third rail. We want to be seen as neutral. So my response to that is actually the way that we practice medicine right now, it is a political project. It's a political and an economic project. We're participating in a system. For example, right now in the US, we know from the Institute of Medicine that their international comparative study that the US spends the most per capita on healthcare of any country in the entire world. Almost 20% of our GDP goes to healthcare, including pharma and biotech. And we have the worst health outcomes of any of our peer countries, any of the industrialized nations, by any measure. That is a crime. How is it that we could be spending so much of our nation's wealth and getting such poor health outcomes? Well, for one way that we stick out among all of our peer countries is the degree to which we have deregulated healthcare industries and privatized them. So what that means is we've given control over, and the story of white opioids really illustrates this too, because it happened as a result of an era of deregulation of pharma industries, right? So that claim that Purdue Pharma made about the non-addictiveness of OxyContin was allowed to stand in an era of deregulation. So we, as a country, have set up a political system that has greatly strengthened for-profit entities, pharmaceutical companies, biotech companies, health insurance companies, to set the national agenda on how we spend our healthcare dollars and how we practice medicine. And I'm going to bet if anyone on this call thinks about it, they know many instances in which the way that they practice medicine is dictated not by the best interest of the patient, but by the constraints that are imposed on them by for-profit entities. For-profit entities, their loyalty is to their shareholders. Their loyalty is not to public health outcomes by any measure. So we as public health practitioners or health practitioners, clinicians, our loyalty has to be to patient outcomes. It has to be that. So there's inherently a conflict there. I'm not talking about a political party. I'm not saying that we have to come out in favor of one party or another or that level of politics, but we must recognize that we are practicing in a political and economic system, and that if we don't address that level of influence on our healthcare, then we are harming our patients because we are participating in it by definition. So there's no way to stand outside of politics and practice medicine. And what I mean is politics writ large. I'm not talking about an easy answer through one party or another. I'm not talking about that. I'm just saying we have to have a much better understanding of how our systems work, how our healthcare system is funded, how certain kinds of care are incentivized, and why it is that our country operates so differently than others and gets such different outcomes. Because we have that responsibility too. We carry a certain amount of weight as healthcare practitioners to weigh in on these issues, to say, no, this is harming patients. We need to revise the system. We need to have better regulations. We need to have a better system for incentivizing certain types of care. That is within our responsibilities. So that would be my answer to that, is that it's not that we have to pick a party as a profession. It's that we have to understand the ways that our practice is shaped by policies and institutions, and step up to the plate to work towards health promoting institutions, policies, and practices.
I don't know if you can answer one more question in
Sure.
5 minutes, but there was a question about, you made a comment about the language that we use to describe patients and having more intimate conversations with our patients about their identities, and not just their racialized identities, but just their identity in general, and their hierarchy of needs, where they fit in that and how they see themselves. And oftentimes, if you're in training, you may have a supervisor who say, well, asking the patient about their race may impose your own implicit biases or impose your own views, and that may be uncomfortable for the person. So what is your stance on how do we apply the technologies of whiteness to history and current practices within the field of psychotherapy?
Oh, that is a fascinating and very complicated question.
Denise, where are you?
So yeah, and so I don't know that there's an easy answer here. I think that just like there aren't easy answers to the other big problems of healthcare, and particularly in our field of mental health, our goal is to get a much better understanding first of all, on the patient level. How are they seeing themselves? How is race operating for them? And then on the structural level, how is race, the way that it's embedded into our institutions and our public policies influencing them? And so I think that's the first step. And there are some general approaches, some general principles that we can follow. But I might need to ask you, though, to tell me the specific part of the question. So that I can anchor it. Because
I'll read it. I have been told psychotherapy supervisors that bringing up a patient's experience of their race means that we're bringing our own assumptions into the psychotherapy, and this somehow imposes our agenda on patients with strategies in psychotherapy that aren't as well established as practices that's popularized by Freud, Winnicott, and others. I can present and demonstrate complete proficiency.
Okay, so the real question is, do I bring up in a patient encounter how they think about their race? Mm-hmm. If it doesn't organically come up in the conversation, right? Mm-hmm. So, and so that's where we need a lot more clinical skills. The way that we practice psychotherapy in the mainstream of psychiatric care has largely been shaped by white, affluent physicians that haven't had as much sophistication about race as other topics. Let's just be very frank. And so we're living in an era where it's just undeniable how race is permeating our daily lives. And it may, there's a lot of skill involved in exploring different topics that could be relevant to patients. There are many different kinds of issues that you might not bring up directly with a patient in the first encounter, right? You might keep them in the back of your mind and look for opportunities and listen very carefully to how a patient talks about these issues themselves, whether directly or indirectly. I think we should be listening much more to leaders in psychotherapy and psychiatric practice who have developed techniques and real skill set in this, how to have conversations about race with patients. I can't give you a simplistic answer because that would be asking for a simplistic answer to a much more nuanced and complex topic. But there are people way more skilled than me in psychotherapy who have developed consciously approaches for approaching race in the psychotherapeutic encounter. Okay, and we need to really elevate their work because it's a refined skill. It's a body of knowledge, just like any other skill and body of knowledge within psychotherapy and in mental health treatment. So I think that would be my general answer, is that we just need to give the respect due to this area, that it's something that we need to develop much more skill in. And fundamentally, I'm afraid that in the field of psychiatry, we're losing our skill set when it comes in general to how to talk to patients, because so much of the emphasis is on just prescribing a medication. So there are many psychiatric training programs now, residency programs, that provide hardly any training in psychotherapy. And we're creating a whole generation of psychiatrists who are thinking they can offload psychotherapy to non-existent partners, because our healthcare system doesn't fund psychotherapy, and particularly in the public space, right? So what we should be investing our energies even to work within public policy and institution building to make sure that there is space for a conversation to begin with patients, and also within that develop skill in talking about race. We need both, because that's another structural problem. If you don't even have time because of the institutional reimbursement rates and things like that, if you don't even have time to talk to a patient, you can forget about understanding the nuances of race in their lives and addressing their problems on that level. So we have to even start with that.
So Helena, you always bring the thunder and have the wonderful responses that I could never articulate the way you do. But the one thing that I remember doing in my training that probably was different than my peers is I began to explore, like, how can I use the cultural formulation to ask people about race and their other identities? And the responses from the patients was, at first, more harming to me than I thought it was going to be, in terms of them not anticipating that, not being prepared for that, opening up trauma for them because no one had ever asked them to reflect on that before. But the outcomes after doing that for a while and figuring out how to do it right, I feel very comfortable bringing it up in a way and looking for the cues from patients in terms of what they need from me and being a barometer about that. But I don't think that I have perfected it in any ways. I think one of the challenges is there's a zero-sum effect where people say, well, if we do this, it's going to take away from this. If we do that, blah, blah, blah. Who cares? There's a lot of healing that needs to be done in certain communities. And it's also true that it has to be radical because our outcomes and inequities are just growing. It's also true, from my perspective, that if we don't ask those questions, we do more harm because we assume that those people are not living their lives and experiencing that. And we know by what we see that they are. So I really appreciate you taking the time.
Well said. Yeah. And I see in the chat someone is agreeing with by not asking, you're likely to be operating under your own assumptions. We've been living in denial, right? That's what has perpetuated structural racism in our society, is the denial of the impact of race, particularly in medicine. And so you're absolutely right that we create harm by not acknowledging the impact of race, as well as the political institutional structures around us. Absolutely.
Thank you so much. Well, we have to end. Thank you for coming. I put in the link for the lecture that's following for students and anyone who's interested in participating. We'll take a probably 3-minute or 5-minute break just to digest what we learned. And you guys have a good rest of the day.
Thank you so much.
Unmute and do a round of applause for Dr. Hanson. For everybody still on the call.
Thanks so much. It's been a pleasure.